Hi, and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. My first guest today will be myself. So we're back to the old format of the show for this episode, where we're going to be talking about a topic that I actually know a fair bit about. So I thought I would be able to discuss it with you guys and give you guys a whole bunch of useful information. And the topic today is going to be something that you've heard a lot about in the news lately, and that's medications that we use to treat obesity. It's been something that obviously a lot of people have heard of, both ads on TV, they've been everywhere, celebrities using these medications. A lot of you probably have friends or family using some of these medications. And it's a question that we get here in the office quite a bit, asking our opinion on it. Are people eligible for it? What side effects? How do we pay for it? So I thought it'd be a good opportunity for us to be able to dig deep into a lot of these topics today, and to give you some information to digest. So I'll give you a bit of the layout on what we're going to address today. First, we're going to talk a bit about kind of the history of these medications and kind of the biology behind it. How do we get to the point of even being able to use these medications as therapeutic options? We're going to talk a bit about what products are available, some of the indications, whether it's for obesity, for diabetes, some cardiovascular benefits potentially. We're going to talk a bit about the studies. How have they been studied? What trials do we have that have helped us to understand that these medications either work or don't work? Talk a little bit about cost and drug coverage. We'll talk a bit about side effects, and then we'll actually end the show talking about some other weight loss options that you may not have heard as much about, that sometimes we use here in family practice. So bit of the layout, hopefully be able to give you guys a lot of information, because it is a pretty complicated topic. And I find sometimes in practice here, someone will come in and ask, tell me a little bit about Ozempic. And it's really a kind of a 15 to 25-minute conversation. So I thought just exactly the perfect length for an episode to be able to go over that with you today. So let's talk a bit about kind of the history of weight loss meds. So obviously this is something that there's been great interest in for many, many years. Obviously obesity is something that from a medical standpoint, we know leads to a lot of consequences. So we know obesity increases the risk of cardiovascular disease, heart attack, stroke, and peripheral vascular disease, circulation issues to the legs. We know it increases the risk of diabetes. We know it increases the risk of gallbladder disease, and pretty well every cancer as well is increased by obesity. So from a health perspective, it's something that we definitely want to treat. We've seen a transition over time, where obesity from a medical standpoint is treated obviously very, very seriously. And it's not looked at as much of a strictly, issue where someone just needs to eat less and exercise more. We know there's a significant genetic and hormonal component to obesity, where we know people who consume the exact same amount of calories, person A and person B, for reasons outside of their control, are going to hang on to calories quite a bit more. And we know that ultimately that is kind of, not only unfair, but we know medically, if there's something that we can do to even the playing field, we want to be doing that. So despite the fact that some people still have that kind of stigma in their mind where, someone has obesity, it's strictly, is it just their own fault? And we know often that's not the case. And for treatment, it's always been something that we've had difficulty treating. Putting someone on a diet, for instance, or telling them to exercise more, the weight that they lose through those means, we often find not to be sustainable. Now, you're going to have people who have good success with it, and provided that they enjoy what they're eating and what they're exercising, and if they can sustain that, amazing. But we know from studies that have been done over years looking at lifestyle interventions that they, by and large, are very difficult to keep on, and we know that they're generally not very sustainable, which most of you who've tried to lose weight over your life have experienced that, right? Where ups and downs and that kind of frustration with it, and that kind of self-blame and that guilt that goes along with it. So we know that just advising someone to change your lifestyle, while it makes intuitive sense from a family doc perspective, I know that the majority of patients will struggle with that and will struggle to keep it off. So, what have been our options over the years, medication wise? Uh, the medications up until recently that have been available for weight loss have either come with significant cardiovascular risks or side effects that have been so bad that we really have had a hard time justifying putting people on them. So in years past, you would hear about people being prescribed, but more often getting it through kind of illicit means, something called ephedrine, which is a stimulant. And that was linked to significant risk of heart attack. There are kind of famous cases, both celebrities, athletes who actually died taking ephedrine, which was a stimulant, and some weight loss products that you may find on the internet that claim to help you lose weight. When they've actually been studied, are actually found to contain still some of this ephedrine, which we know is quite risky. So that's one weight loss med that over the past few decades was available that most docs never actually prescribed. Other meds that were tried, something called orlistat was available for years. The way that worked was basically getting them to not absorb fat in their intestine so that fat would kind of flow through them more readily and they wouldn't absorb it, so they wouldn't lose the weight. The problem is the side effect from orlistat was greasy diarrhea, which, pick your poison. Do you want to lose weight? But the consequence of that is to have greasy poops for the rest of your life. So I can honestly say I don't think I've ever prescribed orlistat to anybody over the years, nor do I think anybody would have taken me up on that offer. So this is where we've struggled for years on what to do. And bariatric surgery, which we've talked about in the episode before, is an option for some patients and probably the most sustainable form of weight loss. But we haven't had meds that we can turn to that are beneficial. So fast forward to now, and now we do have, and excitedly, we do have some options that are safe and effective for patients. So how did we get here? So we're going to talk about a class of medications today called GLP-1 receptor agonist. So glucagon-like peptide receptor agonist. So GLP-1 receptor agonists. This is the class of medication that you're hearing about lots in the news, and you're seeing them prescribed lots. And so how did we get here? So I'm going to kind of tell a story which actually has a Canadian flavor. So Daniel Drucker, he is a scientist, Canadian scientist, did his training down in Boston at Harvard and lived there for a number of years, and did research into discovering a new peptide, so a new molecule that was discovered. It's in our bodies, but hadn't been isolated yet. It's called GLP-1. And they discovered another one called GIP as well. And these are peptides that the small intestine releases, and in response to eating. And this peptide has an effect on the brain in terms of making us feel full, making us feel cravings. It has an effect there. And it also affects your stomach and your gastrointestinal tract in terms of how quickly things move through you. So again, before this was first discovered in the 1980s, and in 96 roughly was the time where he and some colleagues demonstrated that GLP-1, when given to initially mice, but then humans, actually reduced their food intake, which was exciting, right? And it's interesting. You think, 1996 is when they first discovered it, and it took the better part of 20 years now, 25 years to actually kind of be able to operationalize this in terms of a med that we can actually use. So it goes to show how long it takes through this kind of the scientific process to get from discovering something and discovering the promise of something that might actually help us to actually having a drug that is safe, effective, proven enough to actually put on the market. So again, these hormones that are released by the small intestine have this effect. Initially, he did some work on something called DPP-4 enzyme. So DPP-4, that enzyme breaks down this hormone. And his initial work was looking at that enzyme, turning it to a medication that blocked that enzyme, which was found to reduce blood sugars. And that class of medications was actually the first one that came about from this research. And if you've heard of medications like Januvia or Tradjenta, those medications block that DPP-4 enzyme, which boost your levels of GLP. Okay, so That was the first class of medications. And then subsequently to that, now we have these injectable medications and oral medications now, these GLP-1 agonists, which directly boost someone's GLP levels. And what does that do? So the GLP receptor agonists, they bind to the GLP-1 receptor, both in the gut and in the brain, and they do a few different things. They slow gastric emptying, meaning they cause food to move through your stomach slower, meaning that you're going to feel full sooner and for longer. And then they have an effect on two different hormones. They inhibit the release of glucagon, so you get less glucagon levels. Glucagon is a hormone that on its own can actually raise your blood sugars. The other thing that the GLP-1 agonists do is they increase the amount of insulin. And what does insulin do? It brings your blood sugars down. So we know this medication has those multiple effects. And what are the benefits of it? Reduce your blood sugars, which is why we've initially, the initial indication is for diabetes, and we still have lots of patients on it for diabetes. But through the effect of making you feel full sooner, as well as actually affecting the brain in terms of cravings, we know that people can lose weight on it. Because even back well over 10 years now was the first ever GLP-1 agonist. So like the family of medication that we see now with Ozempic and Victoza and these ones that you hear about a lot in the news, the first one actually came about over 10 years ago, and it was specifically for diabetes. Now, we knew from those initial trials that not only did it bring someone's sugars down, but it did bring their weight down. We didn't have enough studies over a long enough period of time to show that weight loss was persistent. So that's why you didn't really see it marketed a whole lot. And we didn't really see it used for diabetes a ton 10, 15 years ago, because we were going through a phase in diabetes where a lot of medications were bringing blood sugars down, but weren't actually preventing heart attack and stroke, which is one of the main reasons we actually treat diabetes. So we had this product that was called Byetta years ago that reduced your blood sugars, and we really weren't seeing it used very much. And the reason why now we're seeing such a boon in these medications is why so much more excitement for treating diabetes is that we have multiple big trials now that show that GLP-1 agonist, this class of medication, in people with diabetes reduces the risk of heart attack and stroke, which is huge. And that's really been a game changer in terms of us being able to actually be more confident in prescribing these medications to someone with diabetes and being confident that it's actually doing something beyond just changing their numbers. Okay, so we saw I'll give you the timeline too. So I talked about this Byetta that was prescribed well over 15 years ago. And then sequentially over the last 15 years now, we've seen within the same class of medication, multiple different products. So first we had liraglutide. So all of these medications end in glutide, Glutide. So any of these medications that you hear, liraglutide, these are all these GLP-1 agonists. So liraglutide, Victoza is the brand name for diabetes, and Saxenda is what's used for obesity. It was initially a daily injection. So this was approved back in 2010, so 14 years ago now. And that's been around for a while. Then in 2014, we actually had a weekly option, which is great. The idea of injecting it someone every day is a bit of a chore. So in 2014, we had Trulicity, which is dulaglutide, and again, still only used for diabetes, still only approved for diabetes at this point. We've been using that for about 10 years now. Then in the last 5 years, this is when we've got semaglutide. So that's Ozempic, which anyone who's turned on a TV in the last year has obviously seen a lot of ads for that. Rybelsus is the oral form of semaglutide. Rybelsus is also used for diabetes, and the same molecule has Health Canada approval for obesity, and that's called Wegovy. What you see a lot with these medications, and part of the confusion, is that someone who is prescribed Ozempic by their doctor may often be prescribed it for obesity, even though Health Canada has not approved it for obesity. I think, well, is this safe? Well, in medicine, we do a lot of off-label prescribing, meaning that we know that there's studies showing benefit. We know it's the same molecule, so we can in our, using our discretion, prescribe something that Health Canada necessarily hasn't approved for that specific issue. So that's where you'll see Ozempic prescribed and prescribed safely again, but that's going to be between you and your physician with that. And so Wegovy, which is semaglutide, my understanding is that over the next month or two in Canada, we're going to have that available for treatment. Right now, we have Ozempic. Anybody who's on these medications or has heard this in the news knows about these shortages that we've been dealing with for the past really 6 months now, and that's been driven by a lot of interest in these products and a lot of, I'll say kind of marketing and buzz behind them. Unfortunately, it's led to a lot of shortages, and for a lot of patients who were relying on them, especially for diabetes, it's been tricky to get the medications that we wanted. So they're on Ozempic, and the shortage of Ozempic, we've had to switch them to alternatives. The alternatives, with everyone going to those, there hasn't been as much available. So it's been a bit precarious in terms of getting these medications. It looks like they're becoming more available now over the last couple of months. And from what I hear, over the next 6 months, it should become kind of more easily accessible to get this class of medication. So we talked about liraglutide, dulaglutide, semaglutide. That's again Ozempic or Rybelsus. There is a new class. So those are all GLP-1 agonists. There's a medication called tirzepatide, which actually affects a GLP-1 receptor and a GIP-1 receptor. So again, two different receptors that work similarly. This is a medication called Mounjaro, which is available now to treat diabetes. There's again another version of the exact same molecule that has Health Canada approval. It's called Zepbound. My understanding, not available in pharmacies yet. The obesity form, the diabetes form is, but again, difficult to access. But bottom line is with these medications is, again, right now, because of how difficult it is to access them, you're kind of limited to whatever the pharmacy has in stock. But we know the good thing about all of these as a class, and we know this from big studies that have been done now in the New England Journal and Lancet, and even recently the BMJ, is that the amount of weight that we've seen in terms of weight loss has been actually quite impressive. So the initial study on Ozempic, so we talk about semaglutide first. This was in the New England Journal back in 2021. And they basically put patients on semaglutide for 68 weeks and another group on placebo to see what the difference was. And they saw a 14.9% reduction in body weight from baseline at the end of that 68 weeks. So roughly 15% weight loss. And they found that around 86% of the semaglutide group actually lost at least 5% of their body weight. So pretty impressive results. And that was kind of the landmark study that really got us excited about what these medications can do. Another study done also on semaglutide looked at a bit higher of a dose for 20 weeks, after which, so all the patients were given semaglutide for 20 weeks, and afterwards, half of them continued on it and half of them stopped it. And they found that the group that continued it actually lost an additional 7.9%. So they got to about 17% total in terms of weight loss over that just over a year. And the group that took the semaglutide and then stopped it for the remaining 48 weeks, they actually gained back about 7%. So they still lost 5% in total, but there was a significant difference between those that continued it versus those who were on it and then stopped it. And the reason I bring this up is a common question I get is that, well, if I start this medication, am I on it for life? Or can I go on it and then go off of it? And really, we need to be looking at this almost as a kind of a chronic condition and treating obesity as a condition like if we're treating diabetes or treating COPD or treating hypertension, where because of someone's underlying genes and kind of hormonal profile, the likelihood of regaining weight after stopping is quite high. Now, that's not to say that if someone goes on it that they can't go off it and we'll never let them go off of it. This is kind of part of the discussion we have, and if someone wants to go off it, they can. But we ultimately need to prepare patients that if we do start it, there is a fairly good chance that we may be wanting to continue this longer term, because the risk of weight regain is fairly high. Now, if someone loses weight and finds that they're in a really good routine, and that weight loss has allowed them to markedly ramp up their exercise and their nutrition, and their cravings really never got back to where they were before, and their intake has stayed low. Certainly, not going to force anyone to take it long term, and nor do we want people on medications if they don't have to be. But just knowing that when we start it, the patients do need to be kind of mentally prepared that we may be continuing this long term. Going to take a quick break, and we'll be right back after this message. Hi, welcome back. Again, we're discussing today some exciting developments with obesity medications, and specifically around these GLP-1 receptor agonists. So we're going to jump into cost and coverage, because when patients come in asking me about this medication, ultimately that is one of the main issues that we need to address. So for cost, roughly these medications cost around $300 a month if it was out of pocket. Now, it may differ a little bit depending on the medication, but roughly that is the cost. Through the Ontario Drug Benefit Program, so that's for patients 65 and over or patients on disability, it is covered. Some of these medications are covered if they have diabetes. The government will not cover it for obesity alone. And then for people with private insurance, it does depend on the insurer. And I tell patients they have to ask their insurer which of these medications, whether one of the daily ones or weekly ones, will their benefits cover. If they have diabetes, generally most will cover it for all patients with diabetes. But if it's for weight alone, many insurers won't cover any of them. Some insurers will cover the daily one like Saxenda, but it depends completely on the insurer. So really they need to be asking their insurer whether it's covered or not, and what the BMI criteria, like what do they have a weight threshold for whether they cover it or not. For side effects, we'll cover this really quickly. So the main side effects people notice when they're on these medications are a few different things. So nausea, rarely vomiting, rarely diarrhea. And if we go slow and titrate our way up, often it's much better tolerated. The initial study showed roughly a rate of around 3%. In practice, I think that's a fair bit higher than that. But again, the longer people are on it for, I often find that they will get better, and the side effects won't be as marked. We've seen some issues around some lawsuits. I'm sure you guys have seen this in the news around lawsuits around these medications for people who had really, really bad side effects from it. Having read the news stories, ultimately, if patients are having side effects, it's important to let their doctor know that they're having these, because any patients I've had who've had nausea or vomiting or any other symptoms from it, we stop the medication, symptoms go away. So making sure that we do have an open conversation with our doctors. Two other kind of quick side effects: pancreatitis, or inflammation of the pancreas. People can get very rarely on this, but obesity itself actually raises the risk of pancreatitis. So it wouldn't be a reason why I wouldn't consider it. And then thyroid cancer, a very, very, very rare cause of a very rare consequence of being on the medication. Studies will either show no benefit, no effect, or show a very, very small effect. I saw a study done last week that showed roughly 0.3 cases per 10,000 person years of being on the medication, so very, very low. Again, it's a theoretical risk, but hasn't stopped me from prescribing to anybody to date. It's important that when people are on this medication that it is not, it's not the only thing we do for weight. And I think people understand this, that it's a tool in addition to nutrition and exercise that are important to bring weight down. So a few things I recommend when people start this in terms of nutrition: they need a lot of lean protein sources. We need to increase their fruits, their vegetable, their fibers, and it's important for them to keep well hydrated. Sometimes a multivitamin can hurt if they're on it, because with them consuming less, they may be consuming kind of less nutrients in general. And if they're specifically avoiding an entire segment of food that they're having before, they might become deficient. So taking a multivitamin can hurt. Again, on the advice of your doctor. Please don't take my advice to take a multivitamin based on today's show. Eating slower, choosing smaller portion sizes, not skipping meals, and getting physical activity regularly are super important while on these medications. And the importance of routine follow-up with their doctor, because just being on the medication, we still need to be following up, regular weights, following in with how it is, because it's too easy just to prescribe an entire year medication and saying, so long, we assume you're going to lose weight and then no follow-up. So it's really important that people follow up with their doctor after being prescribed it. Really quick, other medications that are options, I'm just going to kind of list them out, and people who are interested in it can discuss this with their physician. Wellbutrin is an antidepressant that helps with weight loss. Topiramate is an old anti-seizure medication that helps with weight loss. That is an option as well. And naltrexone is a medication that blocks opiates, but we know in patients who aren't even on opiates can actually block some of the cravings associated with intake and obesity. So again, those are some other options that could be discussed with your family physician as well. And until next time, stay healthy.